just do a basic review of the cardiovascular system. We're going to put most of the emphasis on the heart and the regulation of blood pressure. The cardiovascular system really consists of the heart and all the blood vessels, and the primary function really is to circulate blood throughout the body. The heart is, lies in your chest wall, behind your chest wall, and it's about the size of your fist. It weighs approximately 300 grams. Now, like all cells in our body, our cardiovascular cells are going to age no matter what we do. And as we age, what's important to remember is that, as we age, we actually start to lose myocytes. Myocytes are the myocardial muscle cells that are responsible for conduction. And so as we lose these cells when we get older, or they begin to die off, that actually causes a slowing of conduction. So this puts us at risk for cardiac arrhythmias and bradycardia. So it's not unusual for the elderly. Atrial fibrillation is one of the most common arrhythmias that you'll see in the elderly. And so it's just because of the aging of these myocytes. Cardiac cells will actually fibrose over time as well, and they become less responsive then to calcium transport. And so what happens when you have a delay in calcium transport, you actually have slowing of the action potential. And so you have a delay in contraction of the ventricle. And that's important because patients who are older then are at risk for heart failure, right, or filling problems. So look at the basic anatomy of the heart. Here, when looking at this picture, you can see that we have 4 chambers of the heart. We have 2 atria, a left and a right atria. We have 2 ventricles, a left and a right ventricle. And those two sides of the heart are split by what is called the intraventricular septum or septal wall. If you notice also too that your heart has a sort of muscle layer, so that's your myocardium, very important because that's where your cells are that cause contraction and conduction. The flow of blood through the heart, you just kind of as a reminder of the flow of blood through the heart. It's important to know that. Unoxygenated blood returns to the right side of the heart from the superior and inferior vena cava. It's going to run into the right atrium. Going to go through the tricuspid valve, which is between the right atrium and the right ventricle, and it's going to go into the right ventricle. It's then going to go into the pulmonary system. First, it's going to travel into the pulmonary artery, where it goes into the lungs. It gets oxygenated, and it's going to leave the lungs via the pulmonary vein. Then it flows into the left atrium, goes through the mitral valve, into the left ventricle, then through the aortic valve and out into the body via the aorta to go ahead and circulate blood to the organs. Now, if you notice the aorta here, you'll see that there are at the base of the aorta or at the aortic arch is the where the carotid arteries are. So this is important because when your left ventricle pumps out that large volume of blood, and that blood goes through the aortic valve up over the aortic arch, your carotids then actually get fed very quickly. This makes sense when you think about the first signs of hypoxia or the first signs of lack of blood flow or lightheadedness and dizziness, right? You have neurosymptoms that are usually the first signs of something going wrong with the heart many times. So lack of blood flow, like if your cardiac output drops and your blood pressure drops, patients get lightheaded and dizzy, or they have syncope, again, because the carotids are fed first, so they wouldn't have a lot of blood going north. Unoxygenated blood leaving the left ventricle. If your cardiac output comes out unoxygenated, the carotids are going to get fed, and they're going to sense that there's tissue, that there's hypoxia there, and so patients will have restlessness and confusion as the first signs of hypoxia. So again, just knowing your anatomy can help you understand why those symptoms are symptoms of hypoxia. Also at the base of the aorta are your carotid arteries, actually are there as well. I'm sorry, your coronary arteries are there as well. Coronary arteries actually get fed passively when the AV valve snaps shut to prevent black flow of blood. So the left ventricle pushes that volume of blood out. That AV valve, once the ventricle is empty, snaps shut so that blood does not come back, because obviously it's going straight uphill. And so what happens is that aortic valve snaps shut, and blood does regurgitate, or does sort of land back on that closed valve. And that's when your coronary arteries actually get fed. They get fed passively at this point. It's very important then to have a competent aortic valve to prevent backflow. So think about times when you have an incompetent aortic valve and you've got regurgitation. Now you have less blood going to the coronary arteries. Or if you have aortic stenosis and you have less blood going forward, then you're going to have less blood there as well to fill the heart. And that's why patients with aortic valve issues tend to have a decrease in coronary blood flow. Your heart sounds, your S1 and S2 are the primary heart sounds that you're listening for. Those come from the snapping shut of those those AV valves, your mitral and tricuspid valve, and the semilunar valves. So your S1 comes from the AV valves being closed, your mitral and tricuspid, and your S2 then comes from your semilunar valves, which is your aortic and pulmonic valves snapping shut. So that those heart sounds that you hear are the opening and closing of the valves. This is important because when you're listening out of those areas, you need to be listening for murmurs. So murmurs are created when they're around the S1 and S2 or associated with S1 and S2, because they come from either turbulent blood flow through the valves or regurgitation, so through the valves. So you have murmurs, that are associated with systole and diastole, and you can have murmurs that occur before or after the heart sounds, depending on whether you have regurgitation or you have an incompetent valve and turbulent blood flow through it. So the cardiac cycle, just a simple review of the cardiac cycle. This, you have to know when diastole and systole take place and sort of what's associated with that. The cardiac cycle begins with systole, which is contraction of the ventricle. So your ventricle, your right and left ventricle get fed from the atria, right? So then the volume of blood in the ventricle begins to fill, and there's a pressure created with that. The right and left ventricle then will eject blood forward. The right ventricle ejecting blood into the pulmonary artery, the left ventricle ejecting blood into the body. When the ventricle contracts or ventricular contraction occurs, that's systole. Then after systole comes diastole. Diastole is the relaxation phase of the heart. The ventricles then will begin to relax and fill. Again, they get filled passively from the atria, and the cycle will begin again. This is where your diastolic and systolic blood pressure comes from as well. Basic cardiac electrophysiology. So there's a lot of working parts that go into making the heart beat. You have the mechanical piece of it. You have the ventricular systole and diastole piece of it. And then you also have the conduction system that correlates with ventricular contraction, and so the heartbeat is actually represented by waves on an EKG. So some working knowledge of the conduction system can help you when you're looking at a basic EKG. So just a reminder of the actual conduction system. The heartbeat starts with electrical activity being conducted from the SA node, the sinus node. The SA node is up here in the right atrium. That electrical impulse is generated there. The SA node is actually known for being able to have the property of automaticity, so it can generate electrical impulses faster and slower when needed. So the electrical stimulus comes from the SA node. It travels down the right atrium to the AV node, in where it depolarizes the right atrium. Depolarization and repolarization are important because they kind of go with ventricular contraction and relaxation. So depolarization usually occurs when there is contraction, and repolarization occurs when there is resting and filling going on. So the SA node sends the impulse to the AV node, and that depolarizes the atrium, the right atrium, or the atrium in general, and that is represented by your P wave on the EKG. So the P wave, when you see a nice upright P wave, which occurs before a QRS, the P wave represents atrial depolarization, and that represents the SA node firing. So if you see a P wave on the EKG, then what you have is sinus rhythm. So that is why we call it sinus rhythm, because we are looking for a P wave. If you have an upright P wave, you have sinus rhythm. If you do not have a P wave on your EKG, then you cannot have sinus rhythm, or you do not have sinus rhythm. So once the AV node gets the electrical impulse, the AV node sends that impulse down the bundle of His, which are considered your AV bundles or your atrioventricular bundles, down the septal walls to the right and left bundle branches and out to the Purkinje fibers. So it's a lot longer, it takes a lot longer time to contract or to depolarize the ventricles. They're much larger structures. So as the AV node sends that impulse down the septal wall to the right and left bundle branches and out to the Purkinje fibers to go ahead and depolarize the ventricle in order for the ventricle to contract. That is represented by the QRS complex that's on the EKG. So the QRS complex really represents ventricular depolarization. Now, atrial repolarization is not something you see on the EKG. That occurs during the time of the QRS. It's kind of buried in the QRS because the atria have to repolarize while the ventricles are depolarizing, right? And that's how the cardiac, because that kind of mirrors the cardiac cycle. And then you have a resting phase or a repolarization phase of the ventricle. Again, it's a much bigger structure, so it takes a lot longer to refill the ventricle, and so that is represented by the T wave. So the T wave is actually ventricular repolarization, which is resting and filling of the ventricle, okay? So you also have two intervals. So not only will you measure look at the actual waves, but you'll actually measure the intervals. The PR interval is the time between the start of atrial depolarization and the start of ventricular depolarization. And the QT interval is the time it takes the ventricle to depolarize, contract, and repolarize or fill. So those are frequently two time frames or two intervals that we report out on the EKG. So the mechanics of the heart, so just some terms to sort of review that are important. So we've already talked about systole and diastole. So systole then again is ventricular contraction that's caused by depolarization. So you have depolarization of the ventricle. You know, you see that on the EKG, and that it represents the systolic phase or systole. And so systole results in ejection of blood from the ventricle, right? And when you have an ejection of blood from the ventricle, mostly the left ventricle, that is your cardiac output. So systole is needed to have a cardiac output. Diastole is the ventricular relaxation phase that's caused by repolarization. So again, you look at repolarization of the QT or the T wave on the EKG, and that represents the diastolic phase or diastole, which is again relaxation. So cardiac output then is a very simple equation here. Heart rate times stroke volume equals cardiac output. Cardiac output is actually the amount of blood that's ejected from each ventricle every minute. So it counts the amount of blood that's ejected from each ventricle every minute, so over the course of a minute. Your normal cardiac output is about 4 to 8 liters per minute. So that really is a factor of stroke volume, which is the amount of blood ejected from each ventricle with every beat. So you take your stroke volume, which again is the amount with every beat, you multiply that by your heart rate, and that gives you your cardiac output, okay? So many things can affect heart rate and stroke volume. So anything that affects heart rate, whether heart rate goes up or down, or stroke volume goes up or down, is then going to alter cardiac output, okay? So preload, contractility, and afterload, anything that affects preload, afterload, or contractility is going to affect stroke volume, right? Preload is the amount of volume in the ventricles at the end of diastole. So preload is a measure of volume. It's end diastolic volume. So at the end of diastole, or you're most relaxed, when your ventricle is most relaxed, there's a volume of blood there. Preload is the amount of volume in that blood right at the end of diastole, right before you get ventricular contraction begin. It determines the amount of stretch that's placed on the myocardial fibers. So preload is important because, again, it's a measure of volume. If preload goes down, then stroke volume is going to go down. If preload goes up, you assume stroke volume will go up. Okay? Contractility is the actual force of contraction. So once you have a full volume in your ventricle, you then have your ability of your myocardial cells to contract and make that left ventricle contract in order to push that blood out. Contractility, then, the force of contraction. If you remember the Frank-Starling law, that states that the more the myocardial fibers are stretched, the greater the force of contraction to a point, right? So more volume in the ventricle at the end of diastole signals the sympathetic nervous system, which is going to release epinephrine and norepinephrine, to increase contraction so that you increase ventricular emptying, okay? And this is how the Frank-Starling law works, and really it's about compensation. So the more the ventricle is stretched, the body knows, the heart knows it's got to pump that volume out. So what does it need to do that? Well, it needs to increase contraction. So in order to do that, the sympathetic nervous system helps out. Epinephrine and norepinephrine increase that force of contraction in order to cause that cardiac output to go out. So again, this is how compensation works. Afterload is peripheral resistance. So that is that the left ventricle has to pump against. So it's the force that the heart has to pump against. It's on the other side. Afterload is on the other side of the left ventricle. An increase in afterload increases the workload of the heart. So again, preload, contractility, and afterload, three very key terms because, those affect stroke volume and they have a direct effect then on cardiac output. Cardiac reserve. Your cardiac reserve is the ability of the heart to sort of meet the demands of the body. It does this by altering cardiac output. So your heart has an amazing ability to compensate and to increase sort of pumping function in order to meet the demands that the body needs. So in times of illness, exercise, increased tissue demand, your heart will meet those increased demands by increasing heart rate, increasing stroke volume, hopefully to attempt to increase cardiac output. Again, though, it can only do this for so long. There comes a point when your heart sort of reaches a limit in which it cannot do that, and so when it sort of the ability to compensate starts to diminish, you start to begin to have a picture of heart failure. So the cardiovascular system is actually regulated by the autonomic nervous system, and you have the sympathetic nervous system and the parasympathetic nervous system working together as part of that autonomic nervous system. So the autonomic nervous system really affects the heart and blood vessels. These are considered automatic. They're controlled by our subconscious. The sympathetic nervous system is responsible for our fight or flight. That actually affects heart rate. So if you have stimulation of the sympathetic nervous system, you're going to have a release of epinephrine and norepinephrine, and you are going to see beta cells. There are beta 1 cells stimulated in your heart. Those are stimulated by epinephrine and norepinephrine. When those beta cells are stimulated, the beta 1 receptors are stimulated, then you get an increase in heart rate, you get an increase in speed of conduction through the AV node, and you get an increase of atrial and ventricular contraction. So you get a faster heart rate, you get a faster speed of conduction, so you get a faster heart rate, and you get a bigger force of contraction, okay? So the sympathetic nervous system is responsible for that. The parasympathetic nervous system is considered your rest and digest phase. That's actually regulated by the vagus nerve, which is cranial nerve 10. When you have rest and digest, essentially what happens is the vagus nerve just cuts off the stimulation of the sympathetic nervous system. So you have a lowering of heart rate, a lowering of SA node firing. If you can kind of see where the vagus nerve actually comes enters the heart or sort of lays around the heart there, you get a decrease in SA node firing, so a slowing of the SA node, and you get a decrease in AV node or a slowing of AV node conduction. Okay, very important, because this is, you might have heard the term that the patient vagaled, right? And so they get bradycardic. So again, if you vagal, that's stimulation of the vagus nerve. It's right there at the SA node, so you get a slowing of SA node firing, in which case you get bradycardia. And so sometimes patients can't tolerate that, and they wind up with syncope or they pass out. So that is kind of where that term comes from. In your blood vessels, the sympathetic nervous system is responsible also for stimulating alpha adrenergic receptors. So you get vasoconstriction, which is part of your fight or flight. The sympathetic nervous system will stimulate those receptors in the blood vessels and cause just vasoconstriction. And those are usually located right in the vascular smooth muscle, so right in the blood vessel themselves. You get little peripheral parasympathetic nervous system, on blood vessels. There's not a lot that happens there. Once vasoconstriction is done and the sympathetic nervous system is turned off, you usually can get some vasodilation occur after that. Baroreceptors are important because baroreceptors are actually found in the aortic arch and at the base of the carotid sinus, where the carotid artery begins. And baroreceptors are important because they're very sensitive to stretch and pressure. So when the baroreceptors are stretched, they actually send a signal to the brainstem, which turns off the sympathetic nervous system, and that stimulates the parasympathetic nervous system. So again, they're responsible for stretch. So as the ventricle is filling, right, the ventricle has to have a stopping point at some point, and those baroreceptors that are there actually sense that, and they are what signal the parasympathetic nervous system to vasodilate and lower heart rate. They work in the opposite. They work in opposite with a decrease in arterial blood pressure. Okay, so baroreceptors are important. So blood pressure, what is blood pressure? Blood pressure is actually the measurement of pressure exerted by blood against arterial walls. So blood pressure is actually arterial pressure. As that blood gets sloshed around those artery walls, there is a pressure exerted on those vessel walls. Systolic blood pressure is your peak pressure that's exerted on arteries when the ventricle contracts, and your diastolic blood pressure is the residual pressure of the arteries when the ventricle relaxes. There's always pressure left over in the vessel wall, and you have these two opposing forces that affect blood pressure. So cardiac output and SVR. So you have the actual cardiac output, or the volume of blood that gets forced out of the left ventricle, and systemic vascular resistance. That's the force opposing the movement of blood. So these two numbers equal your blood pressure. Your mean arterial pressure is actually perfusion pressure that's felt by the organs. You can actually calculate your mean arterial pressure, systolic blood pressure plus 2 times your diastolic blood pressure divided by 3. Greater than 60 is really needed to, millimeters of mercury is really needed to perfuse the organs. The organs will become ischemic if you have a prolonged mean arterial pressure less than 60. So how is blood pressure regulated? Well, blood pressure is really regulated by a few things, right? Blood pressure, again, is cardiac output times SVR. On the cardiac output side, you have the heart itself, and you also have the renal system, which is really part of your volume system. And then on the systemic vascular resistance side, you actually have your sympathetic nervous system, and you have vasodilation and vasoconstriction right in the blood vessels themselves. So you have all of these forces that regulate blood pressure. Cardiac output is the total blood flow through the systemic or pulmonary circulation per minute, right? So you have stroke volume, which is the amount of blood pumped out of the left ventricle per beat, times heart rate per minute, okay? Systemic vascular resistance, again, is the force opposing the movement of blood within the blood vessels, okay? The principal factor that determines vascular resistance is the actual radius of the artery itself, right? So how vasodilated or vasoconstricted. So a small change in radius gives you a big change in SVR, right? If you have, think about a straw. If that straw, that lumen of that straw gets narrower, it's going to give you a big change in systemic vascular resistance. So the more vasoconstricted I am, the higher my systemic vascular resistance. And so mechanisms that regulate blood pressure can either affect cardiac output or SVR or both, in which case you're going to have an effect on blood pressure overall. So again, anything that affects heart rate or the inotropic state, which is the force of contraction, you have, if your heart rate goes up, your cardiac output will go up initially, but if your heart rate, after a while, your cardiac output may go down. The actual force of contraction or the state of the muscle is your inotropic state. That can have an effect on cardiac output. Again, if your left ventricle fails to pump or sort of is failing because of heart failure, let's say, or you've had maybe a big myocardial infarction, you might have a loss of that inotropic state. And if your left ventricle can't pump, you're going to have a loss of cardiac output. On the renal side, the renal system is really important because it controls sodium excretion and extracellular fluid. So again, you have the renin-angiotensin-aldosterone system plays into the regulation of sodium and water. So increased sodium and water retention is going to lead to increased venous return to the heart, right? So that can have an effect on cardiac output. The renin-angiotensin-aldosterone system is actually activated by the sympathetic nervous system stimulation in response to hypoperfusion. So when the kidneys, if you remember where the renal artery is, that's the sort of beginning of the kidney, the renal arteries, blood has to flow through those renal arteries into the kidney, and it does that every minute. So when there's hypoperfusion to the kidneys because of that renal artery, either there's renal artery stenosis or there's just a low flow state, the kidneys sense that very quickly. In response to that, they say, oh, I must need more water. So they stimulate the renin, they release renin right from the kidney. Okay, so renin is a very potent vasoconstrictor. You get angiotensin 1 to angiotensin 2, and then you have a release of aldosterone, which stimulates the reabsorption of sodium, and with sodium goes water. So you get an increase in blood volume and that will increase cardiac output in the short term. Okay, the long-term effect of that, though, is not so good. You also have natriuretic peptides. Natriuretic peptides are actually made by cardiac muscle cells. That's your ANP and BNP. You may be familiar with BNP if you've studied heart failure before. So natriuretic peptides are actually supposed to stop the effects of aldosterone and ADH by promoting excretion of sodium and water, which then the net effect of that is to hopefully reduce blood volume. So you can see that as the kidneys have this RAAS system working, you get an increase in blood volume. That puts stretch on the cardiac muscle cells. They begin to make BNP in order to stop aldosterone from working, and in the hopes that the kidney will then excrete more water. So the kidney does play a huge role in blood pressure regulation. On the sympathetic nervous system side, that is going to have an effect on systemic vascular resistance. So the increased sympathetic nervous system activity is going to actually increase heart rate and contraction, and that's going to produce some widespread vasoconstriction of both your peripheral arterioles, and it's going to promote the release of renin from the kidney, right? So what you wind up with is an increase in cardiac output and an increase in SVR. The good thing about that is that it's going to increase blood pressure. So again, in response to hypotension or low blood pressure, this system will help in the short term improve cardiac output, improve SVR, or give you some vasoconstriction to hopefully improve blood pressure. And so what happens is the baroreceptors in the carotids and the aortic arch sense a drop in blood pressure. They signal the brainstem where the sympathetic nervous system is stimulated to release norepinephrine and epinephrine, and those are going to innervate nerve receptors in both the heart and vascular smooth muscle. So you have alpha-1 receptors and beta receptors. Alpha-1 receptors in the heart and vascular smooth muscle. You have alpha-2 receptors only in the vascular smooth muscle. So when alpha-1 receptors are stimulated, you end up with vasoconstriction and an increase in contractility in the heart. And then alpha-2 receptors, you get vascular smooth muscle vasoconstriction. You have beta receptors, you have beta 1 and beta 2 receptors. You have beta 1 receptors in the heart and the kidney. So beta 1 receptors in the heart, when those are stimulated, you get an increase in heart rate, right, which is a chronotropic effect. You have an increase in contractility, which is an inotropic effect. And you have an increase in conduction through the heart, which is actually a dromotropic effect. So you get a lot of stimulation on beta 1 receptors right in the heart. So you get a stronger heart rate, you get an increased heart rate, you get an increased force of contraction, and you get increased conduction through the electrical system. Beta 2 receptors are located in peripheral blood vessels and the coronary arteries. Again, they're activated by epinephrine. When blood pressure, blood pressure may be reduced when you have either withdrawal of the sympathetic nervous system stimulation or you get stimulation of the parasympathetic nervous system. Okay, that's actually going to decrease heart rate and thereby decrease cardiac output. So when beta 2 receptors are stimulated, you can get some vasodilation. And then you have some local vasodilation and vasoconstriction. Your body does have the ability to do that. Your blood vessels actually have something right in the blood vessels themselves called EDRF, which is an endothelin relaxing factor. That actually gets, that's actually nitric oxide, and that gets released right in the blood vessels themselves. That helps maintain a low arterial tone at rest and helps actually inhibit platelet aggregation. So you do get some vasodilation locally just from the release of the EDRF. So you do have this little sort of arterial tone, helps maintain this low arterial tone, so right at the site. Endothelin is actually produced by endothelial cells. Endothelin is a potent vasoconstrictor, so again, if you may have the release of endothelin straight from the blood vessels themselves. So all of these factors do play a role in blood pressure regulation. So the thing for the nurse that's most important is to recognize, that blood pressure can go up or down based on changes in cardiac output and changes in SVR. They all kind of work together, but all of these forces are there to help regulate the patient's blood pressure.